Hello, I'm Mike Magee, and I have this honorary post as a health policy person with the Center for Aging Services Technology, which is a great honor and something that I think has been worthwhile because it allowed me to focus on information technology and how it might be used strategically. People tend to think of information technology as gadgets, or they think of information technology as electronic medical records. But in fact, information technology is a very powerful political lever, which if used wisely can quietly flip a system without anybody really knowing it. Because of its efficiency, because of its reach, because it ignores geography, because it is pervasive in mobile technology resources, because it largely at this point, in terms of mobile resources, ignores one's socioeconomic and racial status. Everybody has a cell phone. It's a very powerful gadget, and I'll speak to that in a minute. But before I do, I wanted to mention, since Monty brought it up, such a good example of the kindergarten in his facility, this notion of advantaging the demographic change from 3-generation families to 4- and 5-generation families, rather than being whipsawed by the complexity of the fact that 50% of current 60-year-olds have a parent alive, and therefore with 1 million over 100 by 2050, you're going to have 5 generations, and they're all going to be competing for the same resources. Rather than, wring our hands about that, strategically, as with information technology, you have to figure out how to advantage it. How do you get care to flow up that generational divide, as with a kindergartner responding to a great-grandmother in the institution? And as importantly, in return, how do you get learnings to flow down that generational divide? If great-grandma has fragile fractures and is in that home because of it, and if her daughter, who's 57, has hidden osteoporosis, rather than that daughter just worry about mom, and once in a while say to herself, how do I get to not become like mom? How do we get her to also think about her 27-year-old daughter, who should have had perfectly formed bones by 20 but doesn't? What do we do for her? And more importantly, what do we do for her 5-year-old daughter, who, if she doesn't use the right behaviors, by the age of 20, the gig's up? In every chronic disease, there are learnings that should be flowing down the generational divide that will help our preventive healthcare system that we're trying to form at the same time as we're managing chronic disease. But I'm not going to talk about that. That's another subject, but you got me going on it, Monty. What I wanted to talk about, a bit triggered by Brooke and Peggy's story, is how much that story hits the point. It affected me on a number of levels. I'm sure it affected each of you as well, but 2 levels it affected me on is, number one, many of the services that you organize within your own home, and granted, you had the resources to do it, but undervisioning is the problem, not overvisioning for health policy people. Undervisioning is the problem. Think big. Think that what you accomplished, we could accomplish for those with the least resources somehow. Don't start by a defeatist attitude on it. But in any case, what happened when you said that to me is I immediately thought of my 4th child who had preemies. And I've used the example of NICUs and how NICUs manage to involve a family in the brick and mortar site, but are able to successfully transition into the home very early with little ones that look too fragile to live. I mean, it's unbelievable. They look like they're not going to be able to breathe. A lot of them are on machines and so forth. And they're so small, you're afraid to even pick them up. And yet the NICU guys figure out how to get those kids back in the home quick with the parents, get the resources there, and manage it. So many of the services that you had for your husband they organize for babies who are this big, this big. And one of the strategic questions is, could the services that you used be also used for other members of the family of different ages? Are we underutilizing the workforce? Since the major issue in healthcare today, the biggest issue is efficiency. How are we going to manage this demographic demand in a more efficient way? And could the answer be taking these mobile resources that are in the home for other purposes and begin to use them for more than one thing, for more than one generation? Since they're in the neighborhood anyhow, since we have the capacity to connect them virtually, could we not deploy them in a more efficient way for multiple members of the family if we had a plan for every member of that multi-generational family? Again, you got me going with your story. There's not much time to talk about these complex subjects. I have a couple of those books there, which you're welcome to take. But more importantly, I'm going to give 10 questions without any answers. But I'm going to post those 10 questions tomorrow at 12 noon on healthcommentary.org. It's one word, healthcommentary.org. And we'll put some informational backup to each of these questions. But I'm not going to try in any way to attempt to answer these questions. What I do want to say is that there is a difference between a specialist trapped in a generalist body and a generalist trapped in a specialist body. I would much prefer all of you to be specialists trapped in generalist bodies. And by that I mean that your tremendous specialist expertise is part of a whole. And the whole is about a humanistic kind of integrated approach to human beings that respects body, mind, and soul. So the true promise of palliative care is that whether the people who started it all realized it or not, they were presenting more of a generalist approach to care than a specialist approach to care, even though many of you are and consider yourselves specially knowledgeable about palliative care. The potential of palliative care is to flip it into what the health system overall becomes. But to do that, you have to have the desire to reach beyond this small segment of the population that you serve currently and influence the care of an entire multi-generational family when you get through the door, because not many caring people get in that door. The fact that you've gotten in the door is a major achievement. Not many people are allowed in that door, but you've gotten in the door, but you're not using your potential fully once you're in the door. So let me just, if in fact the goal were to become a specialist trapped in a generalist body, what is the whole that I'm talking about? Well, here are a few quick things. Health equals human potential. The whole idea, regardless of whether we're starting at age 70 or we're starting at conception, is to get the most potential out of that individual. That requires a customized, personalized plan for every individual, ideally beginning before conception, with alterations in the behavior of mother and father who have not even yet conceived yet, and extending out for 110 years, ideally. In a 70-year-old, you don't have that advantage, but do the best you can for whatever years that remain. The idea is potential. What can you do to influence potential? Secondly, health politics. Here's the deal now. We say that everybody now is going to have health insurance. Health is becoming a human right, but there's a trade-off here, and it's been implied, but it's also been stated. We'll give you access to insurance, but we are going to ask of you greater responsibility. Now, how is that expressed by a specialist trapped in a generalist body? Well, I always use the example of the great Cardinal Bernardine. Shortly before he died, He's talking to 2,000 AMA doctors, and he says, look, in the English language, there are 4 English words that have common roots: heal, health, whole, and holy. And he said, if you're going to heal somebody today, you got to get them healthy. And if you're going to get them healthy, you've got to connect the individual, the family, the community, and society. And if you can do all that, why, that's a holy thing. Okay? That's how a specialist trapped in a generalist body talks about the challenge ahead. So from a health politics standpoint, you got to understand that demographically, demand is going up. Complexity of families is going up. And yet, we are saying that we're going to give more. Well, how's that possible? Unless somehow we leverage these families and these communities to do some of this work with us. It's impossible otherwise. So if you look at the major trends then, the complexity is working against us, and consumerism is at a point now with 25% or more of the families having an informal family caregiver. They're all women aged 40 to 70, and they're all angry. Why are they angry? They're angry not because we're not trying. They're angry because the system is pathetic. The system doesn't work for them. It draws them out of their home for the most stupid reasons. It inefficiently uses them. It puts people in the home occasionally, but doesn't maximize their potential. It inconveniences them and delivers little, and as a result, they get left holding the bag. So we've got complexity, we've got engaged and enraged consumers, mostly women, mostly second generation, trying to take care of mom and dad and grandparents on the one hand and be involved with grandkids at the same time. It's not a winning thing. So what are you left with to deal with? Well, this information technology stuff, like I said, it's not about gadgets strategically. Very little to be gained, really, by gadgetry right now, although eventually all of our appliances will be embedded with these things, much the same as cars now are getting all sorts of gadgetry. And so eventually, maybe there'll be some usefulness to the fact that a stove will turn itself off if you leave it on and so forth. But the real value of this information technology is connectivity, low-cost connectivity. Now, why is that important? Number one, if you can control connectivity, you can recenter the power loop of a sector without permission from the powers that be. So, for example, in this case, just throwing out an example, I could take a current power center that goes from hospital to doctor's office and back to hospital, and I could replace it with a power base that went from home to care team and back to home. And I wouldn't have to ask anybody's permission to try to do that. I might start with something very, very small, or I might start with something bigger if I owned a lot of the pieces. But I could do it, and I could do it at very low cost. So that's one thing. Secondly, I could target connectivity toward those members of my group who are most at risk. So I could preferentially target the resources at low cost to that isolated 18-year-old mother of 2 who will not come to her primary care visit because she has nobody to leave those kids with and it's an unsafe neighborhood. I could connect her to someone 24/7. She would at least not feel as isolated as she feels now, and she'd probably get a lot of the information she needs without a trip to the primary care maternal fetal office. I can use this thing 24/7. I can arm it with algorithms that would customize and personalize it. I can eliminate translation gaps. The issue of translation gaps came up before. I can flip a switch, and that 15-year delay between research finding and clinician using, and the other 15 years between clinician using and patient actually following your recommendation, I can eliminate those translation gaps. How can I do that? By making sure that all these 3 parties use the same software and hardware. If you come into my new network as a long-term care patient, I can give you an iPad that's already loaded with my software. You are immediately on the in. I can identify in your family who's going to be the lead caregiver, and I can show that person how to use this in a simple touch way. And how can I do that? Is it so hard? How do I know it's not so hard? Because I have 2 3-year-old granddaughters who do that. 3 of 9. I've watched them all do it. So, that's doable. So,
Mike, we need to.
I could go on, but let me just finish. I apologize. I'm just going to finish, and I'm just going to read to you these 10 questions again. I'm not going to answer them. The first three are about connectivity. Connect to what? Connect to who? Connect for what purpose? Fourth question, who visits whom? Fifth question, can more than one family member get the services? Sixth question, who's on my team? Seventh question, does the team include the informal family caregiver? Eighth question, do they all have job descriptions, including the informal family caregiver, but more importantly, a new job description for the physician? There hasn't been a new job description for a physician in 100 years. Isn't that odd? In a world that's changed as much as ours, that we haven't had a new job description for a physician in 100 years? It's bizarre. Number 9, does each member have a lifespan planning record? It was brought up this morning, a lifespan planning record. What is my record to enhance my own human potential? If I don't have one, why not? And the 10th question, are the steps that I want to take in the future in that plan, and how do I get them reimbursed? Okay, thank you.